here. We really appreciate the invitation to Pediatric Grand Rounds. So we're going to give you a bit of an update on what's going on in pediatric radiology. Just wanted to give an overview of how our group is organized. We have various sections, and you'll be hearing from some of them. So we have a group in neuroradiology, a group in cardiovascular, nuclear medicine, musculoskeletal, fetal and OB. We have an interventional group, informatics, which is a relatively new group for us, and then a group of generalists and body imagers as well. I just wanted to include this, how to reach us. We'd recently had a referring provider survey that was taken, and one of the feedbacks was that it's complicated to get a hold of us. So I just want to put this number here. I hope it's easy to remember for everyone. We practice at a bunch of different locations. I've sort of listed them here. You can see the little red dots on the map. So we have services all over the Bay Area. And in addition to what is core part of Stanford Children's, we're also covering professionally services out of the Stanford ED, Tri-Valley Hospital in Pleasanton, and also for CPMC Hospital as well. We've had some growing volumes over the years. So you can see from FY16 now, we've almost doubled in volumes. So we've definitely gotten a lot busier and bigger. I wanted to go over just briefly some initiatives before we dive into some more depth with our speakers who are going to be coming up. One bit of feedback that we got from our referring provider survey was that it was difficult to get secondary reads. So we built out a system in Epic. So you can now request secondary reads of studies that were done in another institution and get our professional read. So again, as I mentioned, it's built into Epic, and you have to have a mechanism to upload the images, and that's an app that can be installed at desktops at any clinic that you want. So far, various clinics have requested this, and so we've rolled them out into a number of them, as you can see here. And if you're interested, please feel free to reach out to me, and we can get it added to your clinic as well. A couple more initiatives. One is that we've been building out a whole program in AI for pediatric radiology, and I've listed just a few example efforts in this. We're looking at getting automated measurements on imaging exams. So for instance, like leg length measurements that are automated and therefore more reproducible and reliable. Also, we're working on a project of automated notification of urgent results so that you get a heads up a little bit earlier than you would have otherwise. We've recently launched a domain-specific chatbot. It's using all the developments in large language models that have been taking the world by storm, but now it's very focused on radiology. We have a huge database of information from which these chatbots are operating off of. And then we do a lot of work on image reconstruction to allow our MRI exams to run faster. And one of the feedbacks that we had from the referring provider survey was that it was difficult to get access to MRI for your patients. And as part of the response to that as well, we have a construction of a new MRI suite. It's going to go live in early 2027. And we've been working on that for, I think, over 5 years now. So it's getting closer to fruition. This is just an example of some of the work that we've done in image reconstruction. And so I'll walk you through what this is. So this is an AI technique. So if you look at the top left image, that's a scan that was done 12 times faster than what our usual scans run. And you can see that there's a lot of artifacts here, so it's hard to actually analyze what's happening. The top right image is where you've done the long scan, so 12 times longer, and you can see now a beating heart very clearly. The bottom right image is a deep learning algorithm that works off of that fast scan that's 12 times faster and only uses that limited data and is still able to reconstruct a high quality image. So this is an effort that we launched several years ago. It's now actually deployed in over 5,000 sites, and 80 million patients and growing have had scans with this technique that was developed right out of the Children's Hospital. Just a couple more new services or initiatives. We recently this year launched a transcranial Doppler ultrasound program that's benefiting mostly sickle cell patients, but also our neuro NICU and those patients with stroke. We've also taken on a big effort in lymphatic imaging and therapy. So Ali Syed, who's here, has a big part of that. Avnesh Thakor in IR, and also Greg Adamson in cardiology, and they've been working really hard to build out this program. Another thing that we've been working on is silent MR. So as you know, many of the children have difficulty staying still in the magnet, especially when it makes a lot of noise. This is an example of one of the first silent angiography exams. And so you can see here, this scanner makes absolutely no noise, and you can still see all of the blood vessels. This is particularly helpful for our infants who need an angiogram and do it without any sedation. So that was a few brief updates on some things. Now in more depth, I'm pleased to have here with us Anna Seehofnerova, who's going to be talking about her efforts in building our photon counting CT program. Bruno Soares, who's going to be talking about neuroradiology and his efforts to build up that program, and in particular, one disease he's focused on. Ali will give some updates in more depth on MRI, and Avnesh Thakor will talk about IR. So Anna, please.
Thanks, Shreyas, and good morning, everyone. So I'm going to talk about photon counting CT. As you can see, those two guys are very important for us, for the CT community. The upper one is Alan Cormack, who was the first one to publish a paper on a CT and possibilities to create 3D images from 2D X-rays. And then the gentleman in the right lower corner, that's the Gideon Hounsfield. Not going to go into the depths. This is just to show the equation. I'm happy I don't have to, because I wouldn't be able to do it, especially in English. And this is just the drawing from by Hounsfield about the first scanner that he created in the 70s. So this is just the timeline to show you that the article was published in early 60s, and it took almost 10 years to develop the machine. That was done in 71. Then it took another 20 years to get to the spiral CT. So basically the first one was one slice thickness. So you scan around the patient, you move the patient, you scan around the patient, you move the patient. And it took like 5 minutes to reconstruct 1 centimeter of these images. And then another almost 10 years, in 1999, we got the multi-detector CT. So now we have like several rows of detectors. So, and you can move the patient through the gantry, and it's scanning consistently. Then in 2021, finally, that's quite recent, 4 years ago, the photon counting CT was developed. That's nothing about the tube, it's just the detector. That's the new thing to the CT. And then in 2024, last year, we got it finally here in the LPCH. So what's the difference? So this detector basically bypasses the conversion to light. And this skipping of this step leads to low radiation dose, because there are no septa that would like create this. You can increase spatial resolution down to 0.2 millimeters of slice thickness, so we can really depict tiny structures in the human body. We can also detect photons of all energy levels, and we can tell what energy level we are seeing, and we can filter them, so then we can decrease the electronic noise. Because let's say if we have electrons that are below 25 kVs, we can say this is just a noise, and please remove those from our pictures. So I will show you a couple of images to prove that it's not just words, but we have the proof. Here on the left is the chest X-ray non-contrast, chest CT, non-contrast chest CT from the old scanner. And on the right side, that's same patient year later on the new scanner. I hope you can appreciate the difference in sharpness and more detailed on the right side. And plus, we even decrease the dose. So despite the fact that the patient is older, usually we'll get higher dose because he's bigger. We have to scan longer field of view. The dose was decreased by 20%. And then the guy in the right upper corner is our colleague Amir Sarami, who is leading the CT chest part. When we have the spectral information, so we can basically filter some electrons we like or we don't like. So this one is the image of virtual non-contrast imaging. On the right side, you can see the virtual non-contrast image. On the left, that's the source image with the portovenous face. And you can see that on the right, we basically, we don't see the contrast anymore in the liver, but we see the bright blood in the stomach. So we know that this is blood, not contrast. And on the opposite side of the virtual non-contrast imaging is the iodine imaging, iodine maps, when we basically are bringing up the information of the iodine so we can better see vessels. We can nicely evaluate clots we can use it for better detection in smaller babies for small vessels, because basically that's the thing we are looking for, the iodine. The other possibility for the iodine maps is detection of perfusion defects, like in this one, where it was a tiny embolus in the right upper lobe, and you can see with the, can you see? Hopefully you can see, there is a small filling defect in one of the vessels in the right upper lobe. And it's sometimes difficult to decide if it's really true or if it might be an artifact. But then on the right side, you can see the iodine map with the defect of the perfusion. So that was very helpful. And just to see it in the different plane in coronal, the same thing, occluded vessel and the perfusion defect in the right upper lobe. And now the monoenergetic imaging. So as I said, we can filter different levels, energy levels of the photons, and that can bring us some information, or we can decrease some other information we are not interested in. So with the lower KVs, we are using this for bringing up the contrast again, because the KH of the iodine is very low. It's 33 kV. So if we have 40 kV, you can see that this image has super, super bright blood pool because of the contrast that's there. It's not window level. This is the image we will get from the scanner. And now I will make steps by 20 kV. So this is 60, sorry. This is 80. And you can see how the blood pool is decreasing down. So that's first thing. So basically we are losing the information from the iodine. And we are also, the higher KVs are suitable for imaging with the stents or metal prostheses, because they also decrease the artifacts from this one. So, and just to show you the lowest, the 40, and this is 160 kVs, just to see the difference. It's not window leveling. This is just the image we will get from, and we can window level it, of course, but you can see the difference. Even the enteric tube in the esophagus is less dense on the higher KVs. So that's helpful for the metal artifacts. And now we talked about the spatial resolution that can be up to 0.2 millimeters slice thickness, and I'm cardiac imager. So this is one of the tetralogy patient with MAPCAS, major pulmonary arterial collaterals, that are super tiny vessels that can be below 1 millimeter in diameter. And for us, it's very important we would like to track them down to the periphery and be able to tell cardiology people if there are vessels going into certain segments or not, if they are crossing, if they are fusing with the pulmonary arteries. And we really need the spatial resolution to be able to tell them. Another example would be the volume rendering technique, basically 3D reconstructions. Again, cardiac images. This is for the vascular ring with aberrant subclavian artery coming out of the diverticulum of Commerell. And then the last example of the super spatial resolution is a temporal bone imaging, which is more neuro. I'm sorry that I'm digging into the neuro, but I need to make like a nice bridge for Bruno. So this is image of the temporal bone. And here you can see on the left side, behind my back, stapes, which is the smallest bone in the human body. This one is not even fully ossified, and we are still able to see it very nicely. Here, just if you don't see it. And we are even able to do a nice 3D reconstructions of the middle ear ossicles chain. So this is pretty amazing if you think about the size of the structures that are there. And with this, I would like to give word to Bruno from Neuro.
Thank you. I appreciate the opportunity to present here. First thing I wanted to do is introduce my group. I moved here in 2023, and together with Shreyas, we decided that, with such a strong institution, department, and division, we needed a neuroradiology division that would match the world-class work that was done on other sites. Also because we perform a big chunk of the MRIs in the children's hospitals. So I moved in June 2023 and was lucky to have this guy, Hisham Damouche, which everybody has worked with him would tell you is one of the top neuroradiologists anywhere in the world. And he likes head and neck, like these temporal bones and genetic disease and rare diseases, and help us. We all run so many conferences each month with different services. In 2024, we hired an outstanding clinical radiologist, Mark Halverson from CHOP, who has many Teacher of the Year awards. And you will notice that several of your trainees and residents are now requesting electives in pediatric neuroradiology. He may be one of the the reasons. And he also rebuilt the fMRI program. So a lot of the functional MRI material that I'm going to show here actually comes from Mark's work over the last year. And finally, earlier this year, we were able to recruit this international superstar, rising star, Ana Filipa Geraldo from Portugal. And she is quite interested as well in encyclopedic knowledge of vascular disorders and brain malformations. And you see the summer 2026, we have already recruited an early rising star that is currently in training. So we're getting them very early, and you will meet him next fall. I decided to focus on epilepsy imaging, which is one of my academic research areas, together with neonatal imaging and imaging of the premature brain. And the idea is just to show the multimodality approach and also multidisciplinary approach that we have in these cases. We have weekly conferences with neurosurgery, the neurologists, there are epileptologists, and the whole team that comes together to try to diagnose these kids. Our part is usually trying to find very subtle lesions, in particularly one called focal cortical dysplasia, that if we find and if it correlates to the seizure focus on the EEG, electrocorticography, and they are resected, it leads to seizure freedom outcomes. So it's kind of like a little bit of a holy grail for us, if you will. So with functional MR, which is part of this workup, we're mapping the eloquent areas of the cortex in the brain to decrease the risk of having a post-operative deficit. And that is done for surgical planning of brain tumors. When we want to resect a brain tumor, we can do also tractography, which is showing where the white matter fibers are crossing, in particular motor fibers, but also visual and sensory. And we also use that for language lateralization. A lot of epilepsy that we see is temporal lobe epilepsy. And for that, you may need to resect or ablate the hippocampus on one side and parts of the temporal lobe that could compromise receptive or expressive speech. So we learn some functional neuroanatomy, as I'm showing here. And I'll show you some examples. These come from Mark Halverson's work. On the left, you see all these areas, these colorful areas are showing parts of expressive language. Not sure if you can see my arrow. No, but the expressive language is in the frontal operculum, so near the frontal part of the brain in orange. And the yellow blobs more posteriorly are near Wernicke's area, so more receptive language, and extreme dominance on the left side. And that's a good thing because in the temporal lobe on the right side, this child has a pleomorphic zentroastrocytoma. So it's an infiltrative glioma that is taking most of that temporal lobe. And we can establish that there will be a low postoperative risk of language deficit. We also map the motor and sensory cortex using the classic old definitions of the homunculus. And for example, here is a child that was operated for epilepsy for a dysembryoplastic neuroepithelial tumor, a DNET. It's a benign tumor that is only resected because it causes a lot of seizures and refractory seizures. There's not much of an oncologic malignant potential there. And knowing that this tumor was very medial, you see that we're almost at a midline cut, Mark was able to do tasks with the child, and we have a whole team on MRI that practice with the child. It's kind of like having the meeting before the meeting, and it's much more important. And when the child goes into the scanner, they know what to expect, and moving and wiggling their toes, he was able to get these very statistically significant, highly precise activation of the areas of motor areas in the lower extremity that are at the margins of this tumor, indicating that our surgeons have to be very careful and take as little as possible to achieve a gross total resection. And that is usually performed with electrocorticography during surgery. We're also very lucky, in addition to being one of the maybe 3 children's hospitals with a photon counting CT that Anna has showed the amazing images that we can get. We're also one of the few children's hospitals with a PET MRIs. That means we don't have to co-register images after we acquire on PET on MR. It's one single bore, and the images are acquired simultaneously. which is much more comfortable for the child and much more precise in terms of having the superimposition of the metabolic images of the PET and the anatomic images of the MRI. So I'll show you this case. This was a 15-year-old, 16-year-old that had seizures since 5 years of age, and they would always start in the right hip and then go to the down lower the extremity with some shaking and then generalize. And he has had a few MRIs, and we knew from EEG that there was a focus perhaps near the vertex. And on several MRIs, this was undetected. And knowing the seizure semiology, this is a case, we have so many cases and good calls from everyone, but this happens to be one that I read. And we looked at the medial part near the leg area of the homunculus, and we see that this gyrus is a little too deep, abnormally oriented, and a little blurry on this image called T2 flare. See how it's a little bright? And you can see this is normal cortex, very sharp interface of the cortex and white matter. And the arrow, I'm sorry, I forgot you can't see my arrow, but the arrow on the middle image is pointing to where the cortex is slightly thickened and blurry. Then you see an image of a PET on the right-hand side upper corner, where this lesion is actually showing that it's hot, high uptake on PET. That's because this is not an interictal PET where there would be hypometabolic. This child is having 60 seizures a day. And I saw the child in a wheelchair, not being able to communicate. And 6 months after the surgery that resected this lesion, the neurologist and neurosurgeon got a card from the family saying that the wheelchair had been donated, the walker was collecting dust in the corner of the room, and this Christmas, thank you for giving us our child back. And I got a tap in the back from the neurologist. Case number 2 is a case that, this was a long time ago, but I think this MRI was initially read as negative, but we see the fact that the interictal PET, there is hypometabolism in that left anterior temporal lobe that you can see in the black and white image, and also on these images fused to the MR. Compare on the coronal image, the temporal lobe on one side and the other, and you see that there's less red on the left side. That forced a second look at the MRI, and the yellow arrow is pointing to this very small encephalocele, meaning a defect in the middle cranial fossa through which brain is herniating and being irritated. The left-hand side image with the colorful blot is a subtraction of a blood flow study. We don't do a lot at Stanford, even though we have the capability to do it. It's a SPECT, ictal and interictal, and then you subtract and you see where the blood flow increases during an epileptic crisis. And finally, I wanted to show some research of my group. We've been working with AI methods to try to automatically detect these lesions. And that comes from a little bit of personal frustration. I think even in top hospitals, these subtle lesions, we probably still miss them 10 to 20% of the time. The literature shows that up to 78% of these very subtle dysplasias can be missed. So we have state-of-the-art imaging. We have highly skilled, well-caffeinated neuroradiologists. So we're finding most of them, but we need to democratize and expand that knowledge outside of the children's hospitals. So we use different softwares that are open source and try to get to our, to tweak them to get to our own solution. So for example, this is a 16-year-old patient with drug-resistant epilepsy. The EEG is pointing somewhere in the lateral frontal lobe on the right side. We adjust our window. This is the same flare sequence as the first, but we adjusting and we're seeing this slightly bright area that has that little tail that the white arrow is pointing to, and that's the transmental sign indicating the abnormal migration of the neurons from the ventricular zone to the cortical plate, causing that blurring in the cortex. So this is a focal cortical dysplasia type 2 with a very high potential for seizure freedom outcome if adequately treated surgically. This is what we want to do, identify these early, treat them early, and prevent maladaptive myelination and neurodevelopmental impairment that will come from it. This is an example of one of the AI models that we work on. It comes from the UK, And it's not a black box. As you can see, it can find the dysplasia sometimes, and it can also tell you, if you look at this list and bar plots, it are showing you the features on the image that is identifying as present in that cluster, in this case, a dysplasia. So it's an explainable AI model. With that, and that's my last slide, we are taking these tools, and you see on the left side, GraphMeld is one of these tools that I showed. FreeSurfer is a segmentation tool. Then we meld them together, or we put them all together. We try to find where the post-processing is failing. So it's technical work, and we're always reaching out, and I'm always reaching out to the research divisions in our department, engineering, computer scientists, and our wonderful postdocs as well, to be able to run a pipeline that will eventually give this output with more precision. Thank you so much.
Okay, so next I'm going to talk about some updates in MRI. We could probably fill the whole day talking about fun new things in MRI, but since everyone has some work to do, we're going to limit it to potpourri of just sort of 3 things. I'm going to talk about MRI and pacemakers. I'll talk about a new stress MRI program that we have, and then I'll talk about our rapid or targeted MRI program as well. So we'll start off with talking about pacemakers. As many of you probably know, historically pacemakers were considered a contraindication to MRI. And that's because pacemakers, especially like in the 80s and 90s, had components in them that would interact with the magnetic field and basically cause malfunction or potentially cause heating. But since about 2011, there has been MRI-capable pacemakers that have been introduced into the market, and these are very common. And generally, the way that the vendors have gone about this is to put these pacemakers and test them such that they know that they'll be functional in an MRI scanner, but only under very specific conditions, right? And so that's what we often refer to as MRI conditional. So you have to put the scanner into a special mode, put all these parameters in, and only then is it safe to scan these patients. And we've been scanning those patients for many years, but unfortunately for pediatric patients, there still has been some friction on getting MRIs done for patients that have pacemakers. That's because pediatric patients often have non-traditional pacemaker systems. So they may have epicardial pacemakers. They may have generators that are implanted in the abdomen. They may have any variation that we wouldn't typically see commonly in adults. And frankly, these have been historically labeled as MRI unsafe, but not because we know they're unsafe, but because they fall into this untested category, but could conceivably cause harm. And frankly, it has not been financially motivating for the vendors to test these scenarios, since the install base in adults is quite small, and the cost of getting an FDA conditional label and doing that testing is millions of dollars. Of course, in the pediatric community, we don't want to deprive the patients of MRI if we think that they'll actually benefit from them. And so the question is, are these really unsafe? And this is a question that the pediatric radiology and cardiology community became really interested in over the past 10 years or so, and several papers were published, including multi-center studies. And you can see I've just picked some of them here, showing that you actually can scan these patients, especially like those, for example, with epicardial leads or those with abandoned leads. And most patients don't have any issue. You can see in this first study that I have up at the top here, there was one patient who had a transient sensing lead decrease, another study of 104 exams with no detectable change. And really on the back of this, we moved last year to try and implement something where we could also offer our patients who have epicardial pacemakers or abandoned leads or things like that, such MRIs. And so our first patient with epicardial pacemaker was actually scanned in February 2024. It was a patient who had a cardiac history, but needed a spine MRI. And we were able to go ahead and do that. And since then, this program has just grown. So functionally, what does this mean for someone who has a patient? It's hard to know exactly what their pacemaker system is. Can they get scanned? Can't they get scanned? And the system that we've essentially developed for ourselves here at Packard is, if you have a patient and you think they would benefit from an MRI, just order it. And when that order gets placed and it gets routed to us in Epic, then we have our MRI technologists that then research what is their cardiac implanted device, and if so, what is it? I have a little flow chart here just sort of showing, if the patient has a conditional system, meaning the vendor says it's okay to scan as long as you do these certain things, then we just follow that and you go down sort of this right limb of this flow chart, and we just schedule them accordingly. However, if they have a so-called non-conditional system, we're rebranding these. We're not calling them MRI unsafe for obvious reasons. So if they have what we would refer to as a non-conditional system, one of these quote unquote untested systems from the vendor, but has been tested by the scientific community, then it gets routed into this sort of alternate pathway where radiologists will review and basically determine, okay, yes, actually MRI is the best test and will be significantly better than doing CT or ultrasound or something like that. If there's any questions about this, and there often are, there's usually a dialogue with the ordering doc, exactly what are you looking for? Let's think through this together. But if we feel like the MRI is really warranted, then we engage our electrophysiology colleagues. And Dr. Henry Chubb from cardiology has been really critical in getting this off the ground. His partnership has meant everything to us. And we'll sort of review this as a group. Okay, is the pacing system tenuous? Would a transient change in one of the thresholds be catastrophic for this patient? And the vast majority of patients, the answer to that is no. They have a nice, solid pacing system, and typically, Henry and I will have a discussion about it. And if we feel comfortable moving forward, then we will go ahead and schedule the MRI. In those cases, the pacemaker is usually put into a specific mode while the patient goes into the scanner, and somebody from electrophysiology, either one of their physicians or APPs, actually monitors the patient. The patient's put on a heart monitor and monitored throughout the course of the MRI. And we've now done dozens of patients this way. And so this is just a little overall workflow of how MRI works in pacemakers. And I think the take home from this really is that if you have a patient who you think would benefit from an MRI and they have a pacemaker, don't be scared to order an MRI. Many of these patients have been told at other hospitals, at other places, you cannot get an MRI. You can never go near an MRI scanner. Absolutely do not get an MRI. But as I've shown you, that's not really strictly true anymore for these patients. And that's something that we've been doing for well over a year. The second program I want to talk about is another great collaboration with our cardiology colleagues, and this is stress cardiac MRI. So MRI can be used to evaluate for myocardial ischemia. Of course, this is something that's very common. If you walk across the hallway, you go to the adult hospital where atherosclerotic disease is quite common. But we are sometimes interested in looking at, can we induce ischemia in pediatric patients? So I have a little schematic here showing what coronary anatomy looks like. This is kind of, if you're looking from the top down. And so we have sort of the normal coronary anatomy on the top. Then we have one of the more common variants of coronary anatomy, which is the anomalous right coronary artery. And you see it kind of arising more from where the left would come. And that may seem cute that it's a little bit different, but not altogether too damaging. But if you look at this sort of bottom image and say, okay, what happens if this patient vigorously exercise? Now, all of a sudden, you can end up actually causing stenosis at the origin of that coronary artery. And this is something that the pediatric cardiac world has struggled with for a long time. We know that lots of these patients have these and are fine. Some of them are not, and how do we really stratify them? And so stress cardiac MRI has been one of the most well-published things to help stratify them. And essentially what's done is we do a cardiac MRI, and then we do pharmacologic stress. And in this ccase, we would administer dobutamine. We really want that cardiac output to increase. And so we'll put the patient under stress. This dobutamine infusion is supervised by our cardiology colleagues, Shreyas and Sujatha, who are there for every exam, are great partners in cardiac MRI. And then we can get something like this movie that's playing here, where you sort of see the heart beating as the contrast is coming in. And you can see how the muscle goes from being dark to being bright. And that is basically a measure of perfusion. In fact, in the bottom, what I've shown here is we've actually have some techniques that we've been doing research on, where we can actually quantify the cc's of blood that have come in per pixel and try to detect areas that may have slightly less blood flow than others to help make this a little bit more quantitative. We also can do the typical kind of cardiac MRI movies like Shreyas showed. This is an example. You can see that heart beating really vigorously. And again, this would be something that would be really hard to acquire using the old technique, but using this deep learning accelerated technique, we can get it really quickly and not have the patient struggling there during the exam. The last program that I want to talk about is our targeted and rapid MRI program. And this is a program that we've had for several years now. Essentially, this is a program in which we focus on doing MRIs that are very short, 8 to 10 minutes or less in time. And we've, for many years, worked on in-house MRI techniques, essentially custom software that we're writing for the MRI scanners that allow us to do these scans faster. We partner with the vendors on this, and we originally launched this for orthopedic applications. You see an example of a 3D MRI here, where you can see all sorts of great structures. This is, typically to get these types of images would take, probably 20 to 25 minutes, depending on your scanner. And this whole thing is done in about 5 minutes. We've recently expanded this by incorporating some AI components into MRI reconstruction, as Shreyas alluded to. As much as I would love to show you the math, I was told to spare you. So instead, we'll just talk about how we've added some new joints, which is the hip and the SI joint, also looking at hands for effusions. We have a liver protocol that is also under 10 minutes, which allows us to screen for larger liver lesions, get very accurate quantitative measures of hepatic steatosis, of siderosis, and of fibrosis. And we even have a rapid abscess follow-up exam. So instead of getting CT exams for following up on abscesses, you can actually get an MRI that would, again, take less than 10 minutes. Here's just an example of a hip MRI. This is one of our recently launched. And again, this uses a deep learning component to basically make the image acquisition much faster. In this case, these images are acquired in about a minute. So our targeted MRI program, you sometimes see in Epic, we have certain things that are labeled targeted elbow, targeted hip. And what this really is a program that Shreyas was instrumental in launching several years ago, and we've expanded quite a bit over the past 5 or 6 years, and including just this past year, where basically we tie these abbreviated MRI exams to certain ICD-10 codes. So basically, if this is the diagnosis you're looking for, we're confident that this short MRI is going to be able to answer the question. And what having this very short MRI and these sort of confined ICD-10 codes has allowed us to do is use a modifier where we can actually reduce the charge to a third or less of what the typical MRI charge would be. And that in and of itself is very valuable, but it also allows us for many insurers to waive pre-authorization, which means that if a patient's seen in clinic and could benefit from one of these rapid MRIs, your clinic can actually call over to the radiology department and say, I have this patient, I want to get this specific rapid MRI done for them. And in most cases, we'll say, okay, send them over. They can come today. We'll fit them in between other patients. We don't need pre-authorization or anything like that. Of course, it's only available for unsedated patients. And so far, we've only done it on non-contrast exams. But we're always open to engagement on additional applications. So if you have a patient population that you think could really benefit from something like this, please reach out to us. So as a recap, just to cover these things again, pacemakers of really any type are no longer absolute contraindications to MRI. So if you think a patient would benefit, go ahead and put an order in. We have now stress cardiac MRIs, and this has grown so rapidly in collaboration with our cardiology colleagues that we actually do more stress MRIs than the adult side does at this point. And then lastly, we have our rapid or targeted MRI program. These are focus indication-driven protocols that are done very quickly and can be done with reduced charges and increased access. And I think with that, I'll give it to Avi for bringing us home.
All right, good to speak to everyone. So I'm going to talk a little bit about the interventional program here at the Children's Hospital. So back in the days, many of you in this room may or may not recognize, this was our interventional program. This is where we birthed pediatric IR, so to speak, quite appropriate for a children's hospital. And as you can see, we just had a small CR, and we had a little room in West, and we started off the IR program here. And we started to build the collaborations and the infrastructure with the promise that we would get an interventional suite in the new hospital. And so as the new hospital was then built, we were quite involved, as you can see here, in actually designing the interventional suites. And I don't know whether any of you have been in the ORs, but there's a little hump as you walk around the new ORs. And the hump is actually because of the wiring that needed to be actually in place in the ground to allow all the electricity and the infrastructure to support these higher end machines. And at the end of all of the construction, this is kind of where our interventional suite looks like today. So we are one of the largest interventional IR suites in the country. And that's designed because of all the infrastructure that needs to be in place for that. So not only do you have a CCR, but we also need ultrasound. We also need the equipment. And then quite typically, as you'll kind of see from the many cases that I'll show you, we have a lot of people who are very sick. So we have a lot of infrastructure that anesthesia needs, or the ICU needs to come down with multiple drips and everything. So there's a lot of room that's needed to accommodate all of this to allow us to actually operate. So our pediatric IR service currently consists of 3 people, David, Andrew, and myself. We have the schedulers who most of you, if you're ordering a request kind of coming in, will be speaking to either Emma or Kaylee. And then we have the leadership both on the APP with Meredith. We have Kevin with a technologist, and we have Thelma on the nursing side. And between us all, we're kind of managing all the requests that come through to make sure all the kids are appropriately treated as possible. Perform a large range of baseline procedures, ranging from vascular access to enteric management, oncological interventions, transplant interventions. But to kind of stress, we're a 24/7 service line, right? So we're able to take any request at any time of the day. We're attending only, so our requests come attending to attending out of hours. But during hours, you'll meet various members of our APP and nursing team to try and get them scheduled. And if you ever have a question, ring 64747 is our main line. So with that, I'm going to go through a couple of cases to kind of illustrate what we do, right? I'm from the UK, so this to me is football, which you play with your feet. And given the World Cup's coming up, we're going to go through some things regarding football. So these are what I like to call the saves, right? This is where IR came in and we helped out a very critical situation. So this was a situation, I remember this, Christmas Eve, actually you see 2 of them are Christmas Eve, get called and said, we have a 2-year-old, we placed an ART line a couple of hours ago and the baby's arm's gone black. Can you have a look at what's going on? And with these sort of situations, we have to be very careful. I can either send them for a CT angio, but then the baby has a contrast load, so I have a very limited amount of contrast I can actually use in the IR suite to actually look at and try and intervene about what's going on. So there's some scenarios where I'll push them into a CT scan to figure out what's going on. And there's some scenarios where I'll say, just bring them to IR and I'll try and figure it out with an angiogram. So the angiogram here, as you can see, shows an abrupt cutoff, right? So I don't see the axillary artery and the subclavian going into the axillary artery, and hence I don't see any perfusion in that arm at all. And so I eventually figure out that it's thrombosed, so I managed to get through that. And then you can actually see the point of the arterial injury in the dissection that's being caused there. So you can see the little blush in the armpit area. That's this area here. And that's probably where the arc line went in and has dissected the artery and has subsequently closed off the artery, which is why the baby's arm's now ischemic. So after a couple of hours of thrombolytics and re-intervention, I managed to establish the arterial inflow and be able to literally on the same day see the baby's arm go from black all the way to being fully perfused now. So we saved the baby's hand in this scenario here. So that's an example of somebody coming down straight away for a very urgent intervention and trying to get them back up to the unit on the same setting. This is an interesting scenario. So I get called. This was literally, I was at the door leaving the hospital at 5 o'clock. And I get called by the surgeon at Santa Cruz saying, we have a kid who is at daycare holding a glass mason jar, and they tripped and they fell down. And this was a photograph when they got rushed to the ED, and you can actually see the mason jar component still in there. So the mason jar sliced open the baby's abdomen, sliced open the stomach, and the surgeons there went in, washed the stomach out, but kept on bleeding, and they couldn't see the source of the bleeding. So they stabilized the patient and they shuttled them across here. We then saw the CT, which actually Anna showed you of that big blob in the liver. And it actually had dissected the entire of the porta hepatis out, transected hepatic artery, portal vein, hepatic vein. Whilst on the CT scanner, patient had an arterial pressure of 80. By the time the CT scan had finished, the patient had an arterial pressure of 65. So I took him straight from the CT scanner into IR and did the angiogram, and we saw the huge aneurysm that was just bleeding out. So we subsequently go in and we're able to actually embolize all the hepatic artery, portal vein, and hepatic venous outflow so that we get a nice angiogram with no more bleeding. This patient got discharged 2 weeks ago with their liver fully intact, normal liver enzymes, and just a small scar. So we go from here from having potentially an imminent situation of death to a patient going home and having a normal life. Here's a patient, very unfortunate, 4-year-old, had a rapidly growing rhabdomyosarcoma. The tumor was in this proliferation phase and grew so big that it developed abdominal compartment syndrome. Renals shut off, no more urine, pressure increasing, so the surgeons had to go in and open the abdomen. The problem is, as soon as they opened it, they couldn't close it. So now we have a patient in ICU with this rapidly growing tumor, being decompressed, but no way of treating it. So what we did is we subsequently designed a series of staged microwave ablations. So microwave is a technology that delivers high heat to cause tissue destruction. So these are the images on our fluoroscopy suite where we're able to fuse MRI images and guide microwave ablation probes into it. And you can see here, this looks almost like one of the aliens from the movie, kind of exophytically growing out. And over the staged ablations, you can see the tumor shrinking back into the abdomen, so the surgeons can subsequently close the abdomen at the end of the day. And you can see following the ablations, this patient was refractory to chemotherapy. We see a PET avid image, so it's very bright. And then on the last image at the bottom, it's all dead at the end of the day. So the tumor's collapsing in on itself. Another one of the saves, this was the other one on Christmas Eve. Get called in, baby was rapidly born due to imminent kind of decelerations that were seen on the follow-up or the pre kind of scanning in the mother. And we subsequently found that baby was struggling. So they took him down to the MRI. And I think this was kind of late diagnosed prenatally, but ultimately had a large hepatic hemangioma. And this hemangioma was shunting so much blood from the baby back to the heart that you can see the heart in the hemithorax is so big, right? So it was ginormous and the patient was developing cardiac failure. We spoke a lot with the transplant surgeons to decide whether or not to do a hepatectomy at this point in time to remove the tumor. The problem was the heart was compromised and the blood supply to the tumor, both inflow and outflow, was too big that they felt that they probably couldn't safely be done. So what we decided to do was stage an embolization procedure. So this is on a 1-day-old, so we go in here and you can just see the markedly abnormal vascularity here from this tumor. It's just hugely sucking in all the blood supply and pushing it back into the heart without circulating it to the rest of the body. So what we end up doing is we used a very interesting polymer that actually goes in and casts the blood vessels. And you can see here this black cast formed here on all the arterial feeders. So I'm going into each of the individual arteries and actually casting them out to block them here. And over the next day, you can see here the cast in the X-ray, which now goes from black to white because it's a different form of X-ray kind of penetration. But you can see the cardiac silhouette has nicely shrunk. And that now allows the surgeons to go in on the next couple of days to go in to actually resect the tumor in a safer way with a better cardiac respiratory reserve and also have a reduced risk of any bleeding. All right, so the next slide is the defense. So here's an example of a 2-year-old with who had biliary atresia and then subsequently went for a liver transplant. What often happens with a liver transplant is we sometimes have a mismatch, right, between the donor that's coming in and the recipient, right? So often we have to either cut the liver down or use certain segments of the liver, and there's often a vessel mismatch, right? And that's just normal part of pediatric transplant. But sometimes those vessel mismatches can cause areas of narrowing or tightness that limits the blood flow into a particular organ. In this case, this is the liver, and that's the portal vein. And sometimes we can be kind of foxed to kind of say, is that really significant? So these are the sort of things where I'll actually ring up Ali and say, can you repeat this, but do a 4D flow, or can you generate a 4D flow, which actually shows me the flow velocity vectors that's actually traveling through that narrowing to then decide whether or not I should intervene on that. And so this was an example where that's narrowing here in their anastomosis was actually significant. So what we then do is we're able to go in, so we penetrate the liver with a small needle. We then put a balloon inside and we angioplasty that area open. Sometimes it takes 2 or 3 sessions, but then we reestablish blood flow into the liver and all of a sudden the liver can actually normally function. The assist. So this is where we work a lot in collaboration, right? So here's another example of a liver transplant, but in the new transplanted organ, there are multiple biliary strictures, and it's often quite tricky for the gastroenterologist to come up because of the roux reconstructions and actually do an ERCP or gain access to some of these strictures. So what we actually do is we actually work together. So they will come in through the mouth and I will come in through the skin. And we meet in the middle in what's called a rendezvous. You can see this incredibly handsome gentleman right there. And that's Roberto from GI. So he's our lead endoscopist here. So what we'll do is we'll work together on a case to tackle each one of these strictures so we can subsequently either place stents. This is an example of, sorry, a 3D reconstruction that's actually happening, showing the strictures. And finally, we can place stents here, oops, to decompress. Oh, sorry about that. There we go. To decompress it so the biliary drainage goes out and subsequently the liver isn't stressed. And then these will either be managed by the GI team or our team for subsequent repeat angioplasties and subsequently removal of the stents by the GI team. And finally, the attack. So this is an interesting area that we've been developing here in Peds IR, and it's related to bowel-based interventions. So as you can see here, this is the traditional anatomy of the large and the small bowel. And quite often we get called by stem cell transplant for patients who have got significant GI bleeding. And this GI bleeding becomes so significant and is uncontrollable, and they're in ICU at this point, that they ask us, is there anything we can do? So one of the biggest drugs that we can give is a steroid, and a steroid calms down inflammation. But you need to get the steroid to the right place and not just systemically expose them. So here's an example of a patient who's got a large GI bleed, subsequently coming from the large bowel. So we can pop a little catheter into the inferior mesenteric artery, which supplies majority of the second half of the large bowel, and we can actually give targeted delivery of high-dose steroids, okay? We had great success with this, with these children stopping bleeding and actually coming out of ICU and back onto the unit following this localized administration. So we then said, what other diseases are there where you have localized inflammation? And the other one is colitis or IBD. And so now, instead of having the large bowel completely covered, they tend to be very segmental. So we can now go into the branches of the bowel and give a high-dose steroids there. And that goes one more step further, where we can get very, very selective in bowel transplants, where there's often rejection that happens at the level of the anastomosis. But unlike every other organ in the human body, the bowel moves because it peristalsis. So often it's identification on MRI, but then we work again in collaboration with the endoscopist, because what they will do is they'll place a surgical clip at the level of the anastomosis that I can then see. So if the bowel moves, the blood vessels will move with the bowel, but I follow the clip and I don't follow the blood vessels. So I know exactly the point that I need to administer the therapy. And this set the foundation for actually what we're doing right now, which is actually very interestingly, actually, I'm just going to skip through this from a time perspective. Very interestingly, using this to actually now give stem cells. So in patients who have got very inflamed bowels, we're taking the whole process to the whole next, to another level. So we're going from conventional therapies to what we call advanced therapies. So we're actually given mesenchymal stem cells, which have a very anti-inflammatory, very high anti-inflammatory properties, and we're able to give them selectively into the bowel. Not only that, we're actually started to give them into the liver as well. So these are patients who have been refractory to all forms of therapy, even the steroids, and we're actually now locally delivering via the arterial blood supply into the bowel, into their disease segments, and we're able to regenerate the bowel with these stem cells, knowing that they got to the right location. So that's all I have, and hopefully I'm happy to answer any questions.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.